Next up is Dr. Richard Letterman, who is going to be talking to us about the various neurologic problems that can affect musicians. If Alice is the founding mother of performing arts medicine in this country, then Dick is the founding father, having co-directed the conference in Aspen for a number of years with Alice. He's not only extremely knowledgeable and an excellent clinician, but a top-notch presenter on these subjects. And without further ado.
Dr. Letterman, before you get started, I apologize for this. I should have been faster on the draw. We did have one question that came up during the break that related to the last session that everyone answered. So if we could get the answer now. Tell the truth. It is anonymous. How often do you participate, we're talking about you, in a regular exercise program? 1 to 2 times a week, 3 to 4 times a week, 5 or more times a week, or does online gaming count? A recount. This.
That's right.
All right, who can brag and say they voted number 3? We're taking the and and empty out of it. Great job.
Okay. I'm glad I didn't have to vote on that one.
Thank you, Dr. Letterman.
I'm going to talk about 2 broad subjects, both of which could take us an hour each at least. It won't, so don't leave. The first will be about nerve disorders or peripheral nerve problems, and what I will try to do is define this subject, show you a few examples of what kinds of nerve problems musicians get into, and talk a little bit about treatment. We'll then switch to another topic which I think most of you are aware of, but I suspect many of you are not completely comfortable with, and that is the subject of dystonia or focal dystonia. And we'll again try to define that, talk about how it shows itself. I will show you some examples of it, and we'll talk a little bit about treatment of that. First of all, a peripheral nerve, and this is a drawing of a peripheral nerve. If I can get this silly mouse to work, here we go. This is a nerve, a single nerve, which has components of motor, sensory, and what we call autonomic fibers. Every level of the nervous system has many, many nerves, and they are all comprised of basically these elements that come from the spinal cord and project back to the spinal cord. This is a cross-section through a nerve as you would know it. That is a nerve that one can see, that is large enough to be able to be seen, whereas a nerve fiber is not able to be seen with the naked eye. And a nerve consists of hundreds or even thousands of nerve fibers, which are grouped into what we call fascicles, or small groups separated by connective tissue. And these nerves are then what one can see and feel out in the limbs, and they carry messages from the brain and spinal cord to the muscles, and from the muscles and from the skin and other parts of the body back to the spinal cord and brain. Now, we classify nerve disorders in various ways. They can be classified by distribution, and there are disorders that affect all nerves of the body. We call them polyneuropathies. And there are disorders that affect only a single nerve, a focal or mononeuropathy. We can classify nerve disorders by what part of the nerve is affected. The axon is the nerve fiber itself, whereas the myelin is the insulation or sheath that surrounds a nerve. Some neuropathies affect the axon, which degenerates, and some neuropathies affect the insulation or myelin, which surrounds the nerve fiber. And while they may present in somewhat similar ways, they are very different in both how they occur, what causes them, and in fact how they recover. Because myelin readily regenerates, nerves often do not regenerate. We can also classify nerve disorders by what function they serve. Some nerves are purely or almost purely sensory. Others are purely or almost purely motor, and some are mixed and have elements of both. Since most of the nerve disorders that affect musicians are focal or mononeuropathies, we will concentrate our attention on these. In these, the onset is usually gradual and insidious. With trauma, for instance, onset is obviously acute and abrupt. These gradually evolve. The symptoms of nerve disorders include sensory symptoms, of which pain, numbness, tingling, pins and needles, those are the common symptoms. There can also be motor symptoms, primarily weakness. Where do focal neuropathies originate? Generally at very specific places in our body where the nerve is particularly susceptible. You're probably aware of at least some of these. The funny bone is one where the nerve, the ulnar nerve, is particularly susceptible because it is barely protected from external compression or trauma just by skin and a little bit of ligamentous tissue. Whereas other nerves are very deep within the limb or the trunk and are very well padded and are not subject to that kind. But there can be sites where the nerve passes in a channel through bone or between bone and other tight or tense structures, and it can be susceptible to injury there, not from external injury, but from internal injury. And the symptoms that develop as the result of this pressure on a nerve are very specific and identifiable once one knows the anatomy of the nerve and what it does. Now, entrapment neuropathy is a specific localized nerve injury that occurs at one of these predictable sites where a nerve may be compressed. But there are other focal neuropathies that occur from other causes. Obviously, trauma or laceration, stretching, chemical injury, loss of blood supply, even tumors can involve nerves. Now, this slide is a little bit hard to look at and read, but I will, again, if I can get this, here we go. This is a nerve with its nerve fiber and the myelin that surrounds the nerve, that sausage-shaped structure. Now, in some cases where a nerve injures itself or is injured, the nerve fiber is damaged, and in this segment, as you see, it's damaged and it's starting to regrow, and it may grow into multiple little branches. But this segment has been injured and is non-functioning. In the next case, in this situation, the myelin, or the sheath surrounding the nerve, is what is damaged, and you can see that the nerve fiber is still intact, but the sheath around it has been damaged. So these are the main types of nerve injury that we might see, and we can see them in combination as well, so that sometimes when the myelin is badly damaged, the nerve fiber within the myelin degenerates secondarily, and certainly when a nerve fiber is damaged, the sheath surrounding it may degenerate. Now, you've heard before that different practices may report different frequency of injuries. And I put this slide together simply to show you that peripheral nerve disorders are reported in various clinics from around this country and around the world in quite different frequency, depending on who's reporting. Fred Hochberg is a neurologist in Boston, and he reported that nerve injuries occurred in 18% of his patients. Michael Charnas is a nerve specialist in Boston, and in his practice, 48% of his patients had nerve injuries. In mine, about 20 or 21%. In Bill Dawson's, and you've already heard from him, in one of his reviews, 7.7% of the patients had nerve injury. And in a general medical clinic in the UK, Ian Winsper and Christopher Wynn Perry reported that only 4% of their patients had nerve injury. So the doctor's or clinic's specialization has a lot to do with the numbers, and it's a numbers game. So when you read about somebody having X% of their patients with one or another disorder, you have to be very careful and inquire as to what that percentage actually means. You've seen slides like this before, and again, there's a fair amount of data, but the important message here is that in general, string players have more frequent involvement of the left arm, whatever, whether it's a nerve injury or some other type, whereas keyboard players, at least in our series and in a number of others, have more problems with the right arm. In woodwind players, again, in this series, the right is more commonly affected. I wouldn't look too much at the brass players because they're very small numbers, and percussion is also a relatively small percentage. I'm going to show you and discuss 4 different nerve problems, local or focal nerve problems that occur commonly in instrumental musicians. Commonly meaning that of the nerve injuries that we see, these are some of the more common ones. Some will be very familiar to you. I think most of them will be, but hopefully you'll learn a little bit more about them than you knew before. The first is carpal tunnel, which has now become pretty much a household word, and there's so many articles about carpal tunnel syndrome, not only in the medical literature, but in Ladies' Home Journal, that it is something that everybody talks about. But as you've heard, it's probably diagnosed far more often than it really occurs. The symptoms here are fairly typical. There are what we call paresthesias, that is numbness, prickling, pins and needles sensations, that typically occur at night and often awaken the patient from sleep. They are often provoked or occur with certain activities. They are very commonly in both hands, but generally the dominant hand is affected more than the non-dominant hand. Pain may be a very prominent complaint, and it does not just limit itself to the hand, but can even affect the upper arm and shoulder, which is sometimes very confusing, both to patients and to some doctors. The sensory loss, however, is in the distribution of that nerve, and we'll look at that in a moment. Weakness is relatively uncommon, but it does occur, and those last signs I wouldn't worry about. This is not a real live picture, but is a drawing. And it shows you where that median nerve is, which is the nerve that is involved in carpal tunnel syndrome. And it shows you that that nerve is surrounded by a number of tendons that go from the forearm into the hand and control the flexor muscles of the fingers and wrist. It also shows you that on top of the nerve, right overlying it, it doesn't show very well in this drawing, but overlying the nerve is a very dense ligament. And so that nerve is potentially compressed, particularly if there's any inflammatory process involving one or more of the flexor tendons. There isn't much room in there for the nerve to breathe, and that ligament is very unforgiving. So it may be that that nerve will get squeezed, particularly with certain positions of the hand, most commonly pronounced flexion, because that narrows that channel even further. And so that nerve may be squeezed, and that may be the cause of symptoms. Actually, there's a pointer here, but this is a drawing again of the territory, the sensory territory for the median nerve. And as you see, it involves the palmar side of the hand, the thumb, index, middle, and part of the ring finger. Now, it's very common for patients to tell us that all their fingers are tingling, and they're not just imagining this. There seems to be some difficulty that we all have in localizing, but when we test sensation, this is the area that is likely to be impaired. And there's also some on the tips of the fingers on the back of the hand. This is a common position that may predispose, although by itself this is not going to cause carpal tunnel syndrome. But if you have a predisposition to it, and you spend 6 or 8 hours a day in this position, that may be enough to bring on symptoms. Now, obviously, this is one position in playing the guitar. It would be an unusual guitarist who would spend 6 or 8 hours with that much flexion of the wrist, depending on, of course, on what chords are being played. But this is a common way in which we might see the problem present itself. Now, ulnar neuropathy is something that we find most commonly at the elbow. As I mentioned, this is the funny bone. You've all banged it, and you know what it feels like. It hurts, and it feels like something prickling or electrical or tingling. Those are symptoms that can occur spontaneously, and they occur in the elbow and along the forearm and in the hand. There is sensory loss when it is pronounced in the little and ring finger, and those two fingers are the complement, if you will, of the median nerve distribution that we saw just a moment ago. There can be weakness, and sometimes that can be very prominent, and that weakness is in the muscles that adduct and abduct the fingers. You heard that term, you've heard it defined. It's now in your vocabulary, so we can use it. Now, ulnar neuropathy can occur from external compression, and it's said to occur from repeated or sustained elbow flexion. We have some information from our musicians to suggest that sustained elbow flexion is more likely the cause than repetitive elbow flexion and extension. This is a drawing of the elbow and the ulnar nerve, and this is the ulnar nerve here. And as you see, it comes around the elbow, as was mentioned. It has to be loose enough that when the elbow is straightened or flexed, it won't be tightened too much. And then you can see that it goes through a channel here where it also can be compressed. This has been called the cubital tunnel, although unfortunately some of the medical literature calls this entire area the cubital tunnel, and that has been confusing to a number of people, including a lot of doctors. This is, of course, a position that violinists are not infrequently cited in, and it is very common, actually, for this to be a predisposing factor for ulnar neuropathy. Now, you're all familiar with the fact that the right arm in a violinist, at least in the vast majority, is involved in repetitive flexion and extension. So if ulnar neuropathy were caused as much by that as by sustained flexion, which is what we're seeing here, you would think that it would be pretty common in both, or maybe even more common in the right arm than the left of violinists or violists or cellists. It turns out, at least in our series and in many others, that it's almost always seen in the left arm, which to me can be interpreted as suggesting that this sustained position is more likely to predispose to ulnar neuropathy than the repetitive flexion and extension. And I think is a very nice natural experiment, if you will, that gives us some useful information as to what causes these problems. Now, thoracic outlet syndrome is a very controversial diagnosis. Some of my neurologic colleagues would either ignore what I say about it or would refuse to talk to me if I promote the idea that this occurs. I think it does, but it is a very difficult diagnosis to define. I have defined it clinically by the 5 P's. That is pain, paresthesias, it's positional, it can be provoked by specific maneuvers, and it is predictably associated with a normal exam, which is what turns off most neurologists. If a nerve is compressed, it ought to cause some damage to the nerve, and it really doesn't. But we think, and I think, that it is an intermittent compression of the nerve that produces pain, that produces numbness and tingling, but that, for whatever reason, does not cause, fortunately, damage to the nerve. This is a diagram, a drawing that shows you where the brachial plexus is, and this area is the thoracic outlet. Now, anatomists bristle at that because it is, in fact, the inlet to the thoracic cage, but somehow it got called the thoracic outlet by someone who was upside down, I guess. And that's stuck. So we, I think, are stuck with the term. But it is noted that this tangle of nerves passes behind the collarbone. It passes between some muscles that can be very tense. It goes over the first rib, which is barely seen here, and it is compressible under certain circumstances that we think causes symptoms. One of the situations in which it seems to cause symptoms commonly is something that we call the droopy shoulder syndrome. Now, this is a real live pianist, not currently playing the piano, but what you'll see is that her shoulders are very much sloped, and her collarbones, which you can see here, are horizontal. In normal posture and position, the collarbones are sort of angled upward, and the shoulders are straighter across. Now, we can all, most of us, do this if we try, but these people cannot assume a military posture. They don't. This is how they are. And these people seem particularly susceptible, although obviously it does not guarantee that someone like this will develop thoracic outlet syndrome, but this young lady did have it. The final nerve compression I want to talk about is cervical radiculopathy. This is the typical pinched nerve in the neck. And again, it is something that's common for people to complain about. It is something that occurs primarily with aging, although it certainly can occur in young people. Disc degeneration is extremely common, and the numbers are in that first sentence. Some nerve roots or some levels are much more commonly affected than others, and some are relatively infrequently affected. But the symptoms of this are pain, sensory disturbance, and weakness. You've heard these time and again. These are the hallmarks of nerve injury. This is what happens to discs. In the normal case, they are very bulky cushions that sit between the bones, the vertebral bodies, shown here as these spongy-looking tissues, and the disc here in color with a central gel and a surrounding fibrocartilaginous tissue. As we get older, these discs lose water and desiccate, and they get narrower. And as they do, this causes a reaction, and bone grows laterally or in front and in back as well to kind of bridge the gap, and it's a reaction to the degeneration of the disc. These are the bone spurs that can, in fact, compress nerve. And as those bone spurs grow, they will squeeze the nerves that go out next to the vertebral body and through a hole called a foramen, and that's where nerve compression occurs. And that causes pain, and if it's enough, it will cause loss of function, both sensory and motor. Okay, how do we diagnose these disorders? Well, again, as you've heard repeatedly, by a very careful, thorough history and examination. And in many of these cases, it's done whether the patient is a musician or not. But obviously, with musicians, we add another element here. We talk a great deal about what they are doing, how much they're playing, and so forth. And we observe them while they are playing. Now, you might think, for instance, that a violinist who holds the violin and tilts the head to hang on to the instrument might be increasingly susceptible to something like a pinched nerve in the neck. Intuitively, that may seem to be the case, but it hasn't held up when we've looked at our series and others. It doesn't seem to be any more common in those who play bowed strings, particularly violin and viola. If you have symptoms like this or any of the local or focal neuropathies, we're likely to want to do x-rays or maybe an MRI. We also may want to do that feared EMG that some of you may be familiar with. It's a somewhat uncomfortable study, but it can provide us with a great deal of useful information. Treatment of these disorders varies depending, of course, on the disorder. And most of the time, treatment is non-operative, although in carpal tunnel syndrome, it often does require surgery, and surgery is often the definitive treatment for carpal tunnel syndrome. We'll first probably try splinting the hand or the wrist at night so that the wrist doesn't go into the position of flexion that can produce symptoms. We'll suggest resting or modifying activity, but most instrumentalists really can't modify the way they play very much. We might use anti-inflammatory medication, and up until yesterday, we might prescribe Vioxx, but not any longer. We might occasionally give a steroid injection into the wrist, which can be very helpful, but usually temporary, and we might use surgery. For ulnar neuropathies, we can try to minimize the time in which the elbow is flexed. Again, one can't play the violin with a straight left elbow. That's not going to work unless you have a very long violin or a very short arm. We can try to protect the elbow at night or at other times with pads or splints. And there are surgical procedures again, and we won't discuss the different kinds. I'll only say that in general, surgery for ulnar neuropathy is somewhat less commonly effective, still more than not, but less consistently effective than for carpal tunnel syndrome. For the cervical radiculopathy or a pinched nerve in the neck, most of these again can be managed non-surgically with painkillers, with physical therapy for stretching and posture changes, for a neck collar, for using a special pillow at night that prevents the head and neck from being at some odd angle, from traction, which can be helpful, and sometimes surgery is required if there is intractable pain or if there is actually damage to the nerve with weakness or sensory loss. This is an example of another technique for treating cervical radiculopathy. This happens to be a very tall violinist with a very long neck and a lot of space to fill, and an ordinary violin and chin rest didn't work. So we designed for him a special chin rest on an adjustable bolt and designed a very comfortable chin rest for him so that we could fill the space between his chin and his shoulder. And he's been playing on this for almost 20 years. He's had dramatic improvement of his symptoms and has been able to avoid any kind of surgical intervention. This is small enough, thin enough that from the audience, when he's in the orchestra, you can't see that bolt, and it kind of looks like he's kind of playing on air. It's quite dramatic, but he's able to hold his head nice and straight and doesn't have to do this to hold the violin. So he's extremely happy with it. For thoracic outlet syndrome, there are a number of things. Very rarely do we require surgery. Most of these are treatable by pain management, by modifying incorrect postures, by stretching and strengthening muscles to correct the imbalances, and by a program of aerobic conditioning. So these are treatable disorders in a very relatively small series. We found that about 3/4 of the patients with multiple different kinds of nerve injuries were either completely cured or had excellent outcome. A smaller percentage had what we call a fair outcome. That is, they still had some symptoms, but were able to play without impairment. And a smaller percentage still had a poor outcome. If you remember some numbers you saw not too long ago, although it may seem like a long time ago, earlier this afternoon, these are very similar. So it's encouraging to know that various treatment regimens in different clinics have about the same effectiveness. So to conclude this part, let me say that instrumentalists may be particularly susceptible to some injuries, particularly, for instance, violinists with ulnar nerve injury in the left hand, that a lot of these can be seen in instrumentalists, that we can make a diagnosis by careful clinical and sometimes electrical tests, and that conservative treatment is the rule, and surgical intervention can be justified and can be extremely helpful in selected cases. I'm going to go right ahead. Let's see if we can, I think I'll just exit out of this and go right into the dystonia. see, we'll bring this up to, there we go. Now let's talk about dystonia, which you've probably all heard of, but at least some of you, I suspect, aren't sure what it is. I hope that you will be at least a little more sure by the end of the afternoon. This has been defined by a committee of the Dystonia Medical Research Foundation as a syndrome of sustained muscle contraction, frequently causing twisting and repetitive movements or abnormal postures. Now, like most definitions by a committee, it is barely understandable, and the reason for that is that there are so many different inputs that it winds up satisfying no one. But that's the formal definition which has now found its way into the medical literature. This is not a new disorder. I'm not going to read this quote from Ramazzini, who was the father of occupational medicine, and this treatise was written in 1713, although that's the second edition. The first edition was in 1700. And I think this suggests that he was talking about some form of dystonia, which we now call writer's cramp. And I'll show you an example of that in a few minutes. So this is not something new, although the term dystonia originated early last century, just a little less than 100 years ago. Again, there are different classifications for dystonia. It can be generalized, and that's usually a childhood onset disorder. It can be what we call segmental, that is, it can affect a portion of the body, or it can be focal or very localized, like even one finger or one hand or one limb or one part of the face or lip. In the latter case, where it's focal, it may be limited to occurring in just a single activity, like playing the piano or the violin or the clarinet or virtually any instrument. We call these task-specific because if they occur just in playing the violin, it may be that they do not occur in any other activity, even those that use fairly intensive hand activity. That is a very unusual phenomenon, and for much of the last century, that led to the idea that it must be psychological. How could you have something that only occurred when you played the violin or wrote, and didn't occur when you held a paintbrush or played the piano or played the cello, whereas if you played both instruments? That didn't make sense, and when things don't make sense in medicine, we generally assume it's the patient's fault and it's psychological. Don't tell your doctor that, or don't tell him that I said so. There are a lot of terms that have come up over the years for occupational disorders like this, or focal dystonia. My favorite is professional impotence. That was, and these are in musicians and other professionals. This is not in someone who needs to be potent for their professional career. This was the term used by a very eminent neurologist in the 19th century, Duchenne. But you may see any of these terms when you're reading about these things. We don't know how common these things are. There have been some studies, but they're very hard to carry out, and we simply don't have good data. Eckhard Altenmüller, who's a neurologist in Germany and one of the real leaders in music medicine, because of the different health system in Germany, has a better handle on how common this is in German musicians. And he has estimated that it occurs in about 0.5%, or 1 in every 200 instrumentalists, which is a very large number. And that's probably as close as we can come. This is what people complain about when they have dystonia, and it can affect the limb or it can affect the embouchure in the brass or wind instrumentalist. Impaired control is probably the most common symptom, but because the definition includes abnormal postures and involuntary movements, that can also be very common, although less so in embouchure dystonia than in limb dystonia. As you can see, pain is relatively uncommon. Some patients have tremor or jerky movements. Some complain only of fatigability, but those are pretty uncommon symptoms. So impairment of control and abnormal movements or stiffness or cramping are the hallmarks of dystonia. How do we diagnose that? Well, again, we have to go back and take a very careful history of how it came on, how it evolved. And here, watching the person play the instrument is absolutely essential, particularly, obviously, if it's task-specific. If this only occurs when they play the violin, you can't make the diagnosis in the office by watching them wave goodbye or open and close their hand. You must watch them play so that you can see what it is that they're describing. Unfortunately, there are no diagnostic tests that are clinically available that help us in this. So it's purely a clinical diagnosis. Now, I mentioned writer's cramp, and this is a patient of mine several years ago who has writer's cramp. Now, that doesn't look bad to you, I'm sure. She's holding the pen rather naturally, but she hasn't started to write yet. That's what happens when she starts to write. And that is writer's cramp. And as you can see, she's only written 2 words. Actually, it's her name, but I'm not supposed to tell you that. And I should have blocked that out, I suppose, for patient confidentiality. I'll move on. This is today's writer's cramp, and that is computer programmer's cramp, if you will. Look at that right hand. She has the same kind of involuntary flexion and cramping of that hand. This is imposed. This is what happens when she tries to type on the keyboard, whereas the left hand has a much more normal posture. But these still pictures don't really show what it's like. So for the next 3 minutes, I'm going to show you some musicians with dystonia. Watch the right little and ring fingers. And see them involuntarily flex. Actually, it even spreads to the other fingers. This concert pianist is no longer playing at all. This is kind of what Leon Fleischer looked like a number of years ago, and to some extent is still troubled by. Here's a violinist with the same problem in his left ring and little finger. Fairly early on in the course, and you can see that while he can get the finger onto the fingerboard, when he's not using them, they tend to curl away. And obviously, if they're far enough away, he can't get them back in time, and it interferes with his ability to play. He was still playing the Barber Concerto reasonably well at this point, but no longer. This is a clarinetist and a much more subtle involvement of the ring and little fingers, but again, you can see that right little finger curling. Here's a banjo player, so they're not all classical musicians, and here it's the index finger that's curling and affecting the plucking hand, and this was very debilitating to this young woman who is an amateur but very much enjoyed the bluegrass scene, and she was completely unable to participate in that. And here, just very briefly, is a horn player with embouchure dystonia, which can be much more difficult to see. We also had to work hard to block out the face so that it wouldn't reveal his identity. But look at the difference between the left and right side. You can see it best on the nose. When he blows, the nose pulls a little bit to the right. I think you can see that. And this, of course, affects the lip as well and affects his tone. So those are just little brief snippets that show you what dystonia is all about and how it can be so debilitating. Now, what sets this off? Well, you've heard about risk factors or precipitating factors. There are certainly some things that seem to set this off, but I would say less than half the time can we really identify what it is. We think there are also some genetic factors that contribute, but we can't really identify those. There are some forms of dystonia that are clearly genetic, but among musicians it seems to be a relatively unimportant factor, although some people challenge that. Increased playing certainly seems to have something to do with it. It often comes on after a period of intense practice or playing. Sometimes there is some trauma or illness. The concert pianist that I showed you first of the first clip, it came on 6 weeks after he had fallen while hiking on a mountain trip and breaking his wrist. And as he came out of the cast and started to play, that's what happened to his fingers and hand. And that has been a life-changing experience because, as I said, he's no longer able to play at all. Some have emphasized the role of nerve pinching or entrapment in the development of dystonia. It hasn't been a huge factor in my series and in most of the others, but it perhaps is, and we're just not picking it up. What causes it? We don't know. We do believe that repetitive activity has something to do with it, since it involves the left hand of violinists, the right hand of pianists, often the right hand of some wind instrumentalists. So the most repetitive activity seems to be involved, and obviously the lip is in repetitive activity in brass and wind players. There's probably some genetic predisposition, and trauma of some sort may precipitate it. What do we do to prevent it? Well, I'm going to show you that we haven't come very far in 100+ years. This is a quote from Sir William Gowers, who was an eminent neurologist in the UK in the 19th century, talking about writer's cramp and passing the ball right back to you. What does it say? The mode of writing is a matter of education, and prevention rests therefore not with doctors but with teachers. Now, it's not my quote, it's his, and he's dead, so you can't argue with him. This is what Gowers used for treatment, and I'll show you this only to compare it to what we have now. So he said, stop writing, change your style of writing, use a soft quill instead of a hard steel pen, switch to the left hand, use one of those newfangled devices called typewriter, try some kind of tonic like strychnine, sedatives like morphine, cocaine, electrical stimulation, exercise, and massage. So how far have we come? Abstain from playing, retrain, change or modify the instrument, try relaxation and biofeedback, become aware of your body's posture, psychotherapy, medications. So we don't use strychnine anymore, we use artane and other poisons. Surgery, occasionally, botulinum toxin instead of strychnine. Incidentally, not ineffective in a number of cases. And some newer kinds of therapy, including something called constraint-induced movement therapy, or sensory motor retuning for some of us. Not me, I don't like that term. This involves something that has been used in stroke therapy, and that is splinting the dystonic digit or part of the body, and splinting the non-dystonic part and forcing the dystonic digit to be used in a therapeutic session, a series of therapeutic sessions. And that has been reported to be helpful. Dr. Branfenbrenner has used a modification of this with some considerable success. There's another therapy that is in some ways just the opposite of that, and that is limb immobilization, in which the entire dystonic limb, the hand and forearm at least, are immobilized for a period of time. The theory behind this is that in some way this alters the brain's organization of the sensory and motor cortex. And when the splint comes off, it's as if the slate has been wiped clean and you start again with a rehabilitation program. And in some cases at least, the dystonia has been ameliorated or occasionally even disappears. So these are techniques which are still in evolution. They are probably not going to be the final answer for this, but they have been helpful in some. What's the treatment outcome here? Right now, it's not very encouraging. About half of our patients in our follow-up series have had to stop performing. So this is a career-threatening problem. The majority of those who do continue to play report that they have some impairment, but they're able to work around it. And many people are able to do that. They refinger, they modify their repertoire, they do things that allow them to continue performing. The new therapies that I mentioned, it's a little too early to predict, but we are hopeful that they will prove successful. What's the challenge for us in the future? We've got to figure out what causes this, what are the risk factors, what are the mechanisms, how can we identify it, are there tests that we can find that will allow us to diagnose it with confidence, how are we going to treat it, and most importantly, what can we do to prevent it? I'll throw the ball back to you as the educators and teachers, as did Gowers before me. Thank you.
Thank you, Dick. You've heard the crash course version of Performing Arts Medicine 101 for the last 3 hours. Obviously, this is a lot of information to absorb in one afternoon. On the other hand, as you can well imagine, this is just kind of scratching the surface. It's as if one of you were to summarize in 3 hours what you do as your life's work. But it really is the state of the art, and we're fortunate to have heard from these 3 recognized experts in particular. It is, however, the state of the art by and large. We wish there were more science behind it. It's not to say that what you've heard is not scientifically based, but it is, for the most part, based on our clinical experience and the published literature, which describes our and other people's clinical experience. There is a relative lack of what Bill referred to earlier as evidence-based medicine to support what we do in performing arts medicine. When the United States Public Health Service makes recommendations about what the American people should be doing to prevent disease and promote health, They use a rating system to evaluate the evidence upon which they're basing those recommendations. And what I've done in a simplified version here is summarize the types of recommendations or the strength of the supporting evidence. Ideally, what we would like are randomized controlled trials. This is where you get a bunch of people who are similar together. Let's say they're all a bunch of music students. And you randomly assign, by flipping a coin or some other random method, say half of the students to one kind of program and the other half to doing something else, and then you check sometime later to see if one group ends up with more injuries than the other. As you can imagine, this is not something that's being done every day in every music school across the country. Alice actually did a study like this using 2 professional symphony orchestras. 9, right. Assigning them to 2 different interventions, but it's a very difficult undertaking and doesn't always give us the crisp, clean answers we hoped for at first. Now, there are other kinds of good scientific evidence, such as studies that we refer to as cohort studies or case control studies or case series, and we can draw valid conclusions from them. They're not quite as good as the randomized control trial. And then there's everything else, and that's based on expert opinion, trying to extrapolate from things that seem to work in sports medicine and using our best judgment about applying them to performing arts medicine, and then common sense, although, as Will Rogers says, that's fairly uncommon. They're always subject to refinement and clarification in the future. And at the beginning of medical school, the dean told us that 50% of what we were going to learn over the next 4 years would be wrong. He just didn't know which 50% it was. And that's been pretty much true. There were lots of things that I was taught in medical school, and I think our panelists would agree with me, that have turned out with further research to be wrong. Now, I'm not saying that 50% of what you've heard this afternoon is going to turn out to be wrong, but you do need to keep in mind that this is going to be an evolving field, and it's going to be vital for all of us to at least stay tuned to further developments, and I would hope to be, in many cases, actively involved in generating some of that new information. If we don't do it, heaven knows we're not going to be able to rely on other people who are less interested in the subject. So with that as a general caveat, I've tried to kind of distill some of what we've talked about this afternoon into 10 topic areas that could be the basis for part of a curriculum on injury prevention for music students. And I'm sure I've missed things, and after we go through these 10, I'd like to open it up for your comments and suggestions and additions to the list, and we can use that as kind of preliminary discussion to the consensus building that we're going to do tomorrow afternoon. So if we can start with point number 1, and this, for all of these, I'm going to be asking how important is it that students should know the following topic. There are going to be 10 of them. We're going to start with the basics that Bill started with and work up through recognizing what the symptoms of a problem is and how to start treatment and how to prevent it, etc. So this first one is students should know the basics of upper extremity anatomy, and for some instruments there will be other parts of the body that they should be aware of the basics of as well. And you can rate this from 1, not important at all, to 5 critically important. And we've probably got a few people who are deciding. So we've got 40% roughly who think this is critically important, and only 1% who think it's not important at all, and the rest in between. Okay, let's go on to number 2, which is how important is it that students should know the basics of nerve, muscle, tendon physiology? And if the panelists want to get a response device, you're certainly eligible to vote. In fact, you should probably get several votes. Vote early and often. All right, here we've got a slightly lower percentage indicating critical importance, but higher percentage that it's very important. So let's go on to number 3. How important is it that students should know 3, I would remove the word "the", just 3 modifiable risk factors for overuse. And by modifiable, I mean you're not going to change your gender. You're probably not going to change your instrument just to move to a lower injury risk. But the things like modifying your practice schedule, getting regular exercise, reducing stress. I haven't defined what the big 3 are. That will take some further discussion. Okay, and 84% say that's critically important, and I certainly agree, even if you don't know the anatomy and physiology, if you know what you can do to affect your own fate, that's pretty important. The next one is how important is it that students should know the availability of instrument modification? We've talked a little bit about this, and one example was the picture that Dick showed of the tall violinist with the special chin rest. There are other modifications that can be done to the violin even, and to a number of other instruments. Some people are aware of that and some aren't. And 54% saying that's critically important, another 30% very important. Again, this is a way that students can, to some extent, control their own fate. The next one is how important is it that students should know the common symptoms of neuromusculoskeletal problems? You've heard those described for a variety of the common neuromusculoskeletal problems this afternoon. "71% saying this is critically important. And that certainly makes sense, again, in terms of being able to recognize things at an earlier stage where, in most cases, it's easier and faster to turn things around. Next one is how important is it that students should know basic first aid for injuries? These are performance-related conditions. This would be the things you do on Thursday night when your hand begins to hurt before you can get in to talk to either your teacher or someone in the healthcare professions for more definitive advice. 86% saying it's critically important. You know, if you say everything's critically important, then we're just going to have a bigger curriculum. The next one is how important is it that students should know how to access medical care for performance-related problems or injuries? Obviously, this will vary somewhat from depending on the specific setting that they're in, and that will be the subject of our first session tomorrow morning. 66% saying that's critically important. I think next to last one might be how important is it that students should know how to select a basic exercise program. Alice certainly emphasized the importance of exercise in preventing injuries. My bias is that one of the reasons that women tend to have a higher injury rate than men do is that we men are naturally endowed with more upper body strength, and therefore we don't have to use as high a percentage of our maximum muscle strength to do those repetitive motions. A little more spread here, 40% as critically important and 28% each for important and very important. And one of the things I would dearly like to do is generate the data that we need to be more specific about these recommendations. I'm sorry, this is probably the last one. How important is it that students should know proper computer ergonomics? And again, we've talked about how it's not always what you're doing on your instrument that's affecting your hands. Oftentimes, it may be more a matter of the repetitive motions you're doing on other pieces of equipment. And here, the most common response is 37% for very important. And this is, I'm revealing my impending maturity here, but in 1983, when Alice had the first medical problems in musicians meeting, music students using personal computers wasn't a problem. But times change. And this is the last one. How important is it that students should know instrument-specific information? I think most of what we've talked about in these first 9 points would apply to all instrumentalists, and some of it applies to vocalists as well. But there are specific kinds of information that pertain to individual instruments that may be of greater or lesser importance to include in a curriculum. And they're of greater importance, with 84% of you saying that they're critically important. Okay, those are my attempt at 10 things to include in a curriculum. I know I've missed things and I've worded things in a way that could be stated better. We have about 15 minutes for your input, and I'd just like to thank you all for your attention and thank our speakers for really a masterful review of a broad and complex subject.
Dick, I just wanted to ask you, I've heard people talk about focal dystonia and heard that lately the latest treatment is rolfing. Yes? No?
Well, personally, I don't even know what rolfing is. That, I don't know where that comes from, unless it comes from one of the more remote discussions by Leon Fleischer as to what cured him. Now it seems in the last round of publicity that it's Botox that cured him and not rolfing. But in any event, it's a form of deep muscle therapy, and to the best of my knowledge, there has never been anything other than an anecdote here and there suggesting that it's effective. So I don't think that we can consider that a proven form of therapy for dystonia.
Dr. Letterman, you made a reference to research where he had found that 1 out of 200 musicians had dystonia.
Yes. We seem to have intermittent transmission here.
I'm going to try this. How's that? My question is, I was surprised that you commented that is high. I would have thought that's kind of not so bad, 1 out
Well,
of 200. So could you, as a panel, comment on how you determine what is a high statistic versus a acceptable statistic?
well, to me, if 1 out of every 200 instrumental musicians develops dystonia, then if you take two symphony orchestras, someone in that orchestra is going to develop dystonia, and half of those will be disabled. That's a huge number in my book. And given the number of musicians that there are in this country, professional, student, dedicated amateur, whatever, that would keep all of us running constantly if they all develop dystonia. So I consider that a frighteningly high number.
Yeah, and in the population I take care of, that means there would be 4 students at every point in, any time you went in to look who had focal dystonia. We have not had 4 students in 20 years in that population. So at least in that age group.
Yeah, but it peaks in the 4th decade.
Right.
So that I've only had, I think, out of my 165 patients with dystonia, I've had 2 or 3 under 18. So.
But, if we're talking about conditions relevant to the student population, 1 in 200 is just off the map.
I just wanted to quickly sneak in and remind everyone to turn in your little cards with your specific recommendations. We've been getting wonderful participation, and I appreciate it.
3 questions, only one of which I suspect I may actually get an answer to.
That's a pretty good record.
I'll start with the easy one. Are there any circumstances of non-music related injury, but injury which would affect a music student's practice or performance, in which a student should be urged to receive treatment from a doctor with experience in performing arts medicine? And we've had informal discussions about this, in a case of a basic fracture where the student recovers and doesn't need physical therapy. Obviously, that's fairly straightforward, but are there circumstances where a doctor needs to know in treating a contusion, a strain, a sprain, that a student is a musician? And do they need to see an occupational therapist or a physical therapist where that person has experience and a successful track record in working with musicians? Or am I just worrying about something that I shouldn't worry about?
I think that I would push button number 5 on that and say, yes, it is critically important that the treating team, physician, therapists, anybody else, number 1, know that the patient is specifically an instrumental musician, talking from our situation, and knowing the physical requirements, ranges of motion, strength, etc., needed to play a particular instrument. For this, they can depend on their patient to tell them, and they have to be willing to listen and be able to gauge and plan treatment to try to restore as much as possible. Not just treat, but to rehabilitate. Restore to as close to a normal pre-injury status as possible.
And when they go into the emergency room, it is critically important that they tell the emergency room treating doctors. I have had innumerable patients who have gone in with finger injuries. They've x-rayed the fingers, determined that there was no bony injury, but failed to note that there was a soft tissue injury, which was critical for the instrumentalist.
And I assume you're talking primarily about upper extremity injuries. So if it's a violinist who sprains their ankle, Well, it's good to have an ankle that doesn't hurt when you have to stand up on stage, but that's probably less critical than the upper extremity injury.
Okay, here are the ones that I'm throwing a line out and hoping that maybe 10 years from now you'll able to come up with an answer. Increases in practice time, are there any parameters that have been established as safe or parameters that have been established as dangerous? And I'm going to ask my other one at the same time, because the frustration comes from feeling like I know more as a beginning runner than I ever knew as a professional pianist with regard to this. And conditioning, which has been mentioned and documented as inoculating people or certainly helping in creating a body environment that can protect against injury. But do we have any evidence or parameters related to specific instruments? For example, a pianist is very likely to be using muscles in the front and in the arms, and we know anecdotally that a lot of pianists consequently develop weak upper backs. You get muscle imbalances and problems with the agonist-antagonist relationships. Any evidence that we should be doing conditioning as pianists for the upper back, or is that just something where we say, yeah, everybody should have a good, healthy upper back?
We may surprise you. I would say that we can, at the moment, at least tentatively answer both of those two questions. The first question, or your second question, had to do with any information about how much of an increase or how gradually or how much playing is dangerous and how much of an increase would be dangerous. We did a very limited study at a summer amateur music camp that I attend, where many of us who may practice half hour, an hour a day, if we're lucky, suddenly go to music camp and start playing 8 or 9 hours a day for a week or 2 weeks. And we looked at injury rates, and they were rather high at that music camp in that brief time, suggesting that sudden increases in playing are provocative for injury. It's also a pretty common experience for most of us that when we see someone with an injury, and I'll use that term although people don't like it, but we all understand it, that in trying to investigate the factors that may have contributed, there may well be a sudden increase in playing or an increase in what Hunter Fry called the intensity of playing. That is, starting to rehearse or practice for a jury or a recital or whatever. And that very commonly appears to underlie the problem that the instrumentalist developed. So do we have absolute data, 20% increase, 50%, 80%? No. But certainly there is some evidence that a sudden and abrupt, dramatic increase in the amount of playing, or particularly, I think, the amount of repetition of difficult passages during their practicing, that is critical in the development of problems.
We see many more students before jury time, before senior, auditioning for their senior recital or playing their senior recitals than we do at other times during the year. Your second question, you need the upper back muscles just as much as the pectoral muscles, and they are not weak because the pectoral muscles are tight. They are under stress, actually. But you need the upper back muscles and the muscles that support your shoulder blades to give your arm proper support so you can use arm weight in playing on the piano.
To add to that, there is a balance, as I indicated before, between the various groups. I didn't really talk about the balance between flexors and extensors, but it is necessary that you have both functioning at the appropriate levels for any given task. The other thing, based on the second question, the idea of a rapid increase in practice time and or intensity is nothing new. This is not peculiar or specific to music. This has been something that's been known in sports medicine for probably 20 years, or if not 30. Yeah. So any activity, any physical activity with a rapid increase is a potentially risky one.
Thanks.
I'm Gerald Klickstein from the North Carolina School of the Arts. I have a quick question for Dr. Manchester and a quick statement. Question first, we're not mentioning the school that you're referring to, but since the incidence of injury in the top two groups do not line up with the prevalence data, have you been able to do anything to address those groups? Since we're talking about health promotions in schools of music, you have incidence that's very high, higher than prevalence, and that might indicate that there's something going on in those particular studios. So if you could tell us what, if anything, you've been able to do. And then my quick statement is, since you're working on 10 content areas for curricula, I have published a 7-part conceptual framework that I use to train teachers and students in neuromusculoskeletal injury prevention. It's published in the May 2003 American String Teacher. It's a quick summary. It's not all inclusive, but it's called 7 Habits for Healthy Performance. And if anyone wants to look at that and submit comments, I'd be happy to hear what you think. Thank you.
Thanks. Comparing incidence data based on healthcare seeking behavior with prevalence data based on symptom surveys is worse than comparing apples and oranges. So, and if you're referring to the high incidence of injuries in our harp and guitar students, they weren't even included in Hunter Fry's series or in most other general surveys of symphony orchestras, because there's probably one harpist and no classical guitarist, and generally not represented in large enough numbers in other surveys of even music school populations to have been reported in the literature for comparison purposes. We had to review 15 years worth of data to come up with those injuries, and there's problems in and of themselves in comparing data compiled over 15 years, although I was there the whole 15 years. That's by way of getting to answering your question, which is, no, we have not gone to the harp and guitar studios in particular to, grab them by the collar and shake them into submission to reduce their injury rates. But we do have an active wellness initiative at the Eastman School, and we have had that in existence long enough now that we can look at the last few years of injury rates and see if that's made a difference. Now, I'm not going to predict that it necessarily will, because this is not a mandatory part of the curriculum for all students. It's an elective that students can take, and obviously lots of things have been changing in the last few years as well, but that was either my answer to your question or my thinly veiled effort not to answer your question. I think we're at 5 o'clock.
We're okay. We're actually okay. I've got a couple of brief announcements to make. Some of you have requested that dinner be moved a little earlier, so we're actually going to move dinner to 6:30. But it is a buffet, so if you have guests meeting you here at 7, quite all right. People will stay around. But after you eat, please stick around. There's still going to be a concert. There's still going to be presentations. So don't go anywhere. Sit in there. Have a good time. The upside of that is we don't have to clear out of this room now. So we can stay and we can answer questions if the panel is agreeable to that. We can hopefully get as many questions as we can. The cash bar is open outside. If you didn't get drink tickets this morning, please stop by the registration table, and we can provide you with some of those. And then we're still moving forward. Thank you.
But once you have a drink, you can't ask a question.
My question, I don't expect an immediate answer. We've addressed a lot of things about diagnosis and treatment. I'm speaking for the 15% who don't get better after treatment. Rehabilitation seems to be a huge problem, not only with conductors, but in education. had the opportunity to speak with a number of college students who are concerned about losing fellowships, scholarships, and things. I was encouraged to hear that someone was talking about finding alternative things for players to do while they're rehabilitating. Are there any thoughts about drawing up guidelines for educators, that type of thing, regarding a rehabilitation plan, work hardening, that type of thing, if I can use that expression?
You know, I think it's very hard to draw guidelines because every case is somewhat different. And I think that the flexibility in any guideline will be the most important feature. Even within professional groups, you find a tremendous difference in orchestras' willingness to work with players coming back on a work hardening basis slowly, and some that are rigidly, you're either in or you're out. And the same thing applies to institutions. Some institutions are rigid about allowing students not to take orchestra, but to remain registered in school, or not to lose their scholarships. And I think that whatever guidelines are written up should allow for a lot of individual variations. I mean, there comes a point, I guess, where everyone loses patience with someone that's not getting better eventually, and so there has to be some endpoint somewhere. But the more one can see to it that there are creative solutions made to fit the individual's needs, the better, the more salvages you're going to have and the less loss of students.
Yeah, you would hope that common sense would prevail in a situation like that. I was in one of the military bands, as you can imagine. But different bands in D.C. have different treatments. Some people are given recovery time, some aren't. If there were just something, just general, for, on paper for insurance companies or something, that type of thing, it's like an athlete. You don't have an athlete sit still for 2 months and then come immediately back into the situation.
One of the big issues is that insurance companies are themselves so incredibly rigid and cut people off without really realizing that their long-term expenses may be a lot less if they were willing to put in some short-term money.
Thank you.
I wondered if the panel could speak to TMJ in wind players, particularly the instance of it, early symptoms, and what kinds of treatment or rehabilitation can be done with it.
Well, first of all, one has to be very cautious in making the diagnosis of TMJ. It is a grossly overused term. Most patients with, quote, TMJ have basically a muscular pain syndrome. It just happens to be localized to the jaw muscles and is not a disorder of the joint. Misdiagnosis or overdiagnosis is a huge problem in that field, and there's an awful lot of witchcraft, I'm sorry to say, out there involved in treatment programs for TMJ. Not that it doesn't occur, but that there's an awful lot of things that are being done that probably don't need to be done, including a fair amount of surgery that is probably unnecessary. So we have to be very careful about that. Most patients with TMJ can be managed as they can with other muscle pain syndromes by conservative measures consisting of relaxation therapy, stretching, strengthening, etc. Other modalities that are involved, and the vast majority do not need to be treated with these highfalutin interventions that people use. Many people have felt that with the addition of fluoride to the water supply, that a lot of dentists were either out of work or out of a lot of patients because they didn't have to fill teeth anymore. So they went into TMJ work, and while that may be an unfair critique, there may be something to it. So I think we have to be very careful about what we talk about with so-called TMJ.
is TMJ. The state of the art of TMJ surgery is not what the state of the art of other surgeries are. This also brings up a point where, at least in my experience, this has been a situation which has really demanded collaboration between teachers, patient, physician, and dentist frequently to work out a workable plan. Sometimes it's a question of dental misalignment or bruxism of grinding teeth. Sometimes it's a technical problem in how the instrument is approached. And this is the case in point where people need to work together for a solution.
Thank you.
My question is about carpal tunnel syndrome. I'm asking this question on behalf of a very dear colleague of mine who is a 50-year-old female bassoonist. She's my section partner in an orchestra I've played with for 20 years, and during that whole time period, she's had severe problems with carpal tunnel syndrome. I'm sorry. She's often in a lot of pain. She's been to many doctors, not too many doctors, but she's been under a lot of treatment. Finally, 2 years ago, she allowed them to open up her hand, and what they found was she had 2 nerves in there, not 1. And I was wondering if, I didn't know if the nerve split or if this was a freaky thing, but at this point they sewed her back up and have put her back on the same type of treatment. But she's still in a lot of pain. Is there anything else that can be done for her?
Well, I think the first thing that we'd want to make sure of, as I would see this, is to ensure that she has an accurate diagnosis made by, as Dr. Letterman described, all the techniques of making a diagnosis, including electrical testing, and to know for sure that the diagnosis was correct. Now, as to a second nerve, there are not uncommonly what we call anomalies, abnormalities of distal peripheral nerves. And I have seen in 25, 30 years of hand surgery more than my share, or maybe just about my share. The nerve itself may actually be at some point separated into 2 segments, and there may be not two median nerves, but 2 segments of 1 median nerve. In my experience, both segments can be decompressed by the surgical treatment if it is truly carpal tunnel syndrome, because each are equally involved. And the fact that other treatment was deemed necessary after her surgery, and apparently you say she's still having difficulties, I would be concerned as to the precision of the diagnosis.
I wanted to address my question to Dr. Letterman about focal dystonia. I personally know of 3 faculty in our school who have focal dystonia, all bona fide diagnoses, 2 embouchure, 1 jaw, 1 focal dystonia of the embouchure 70 miles away at another university, and 1 graduate student who graduated from one of our Michigan schools who also has it. So those are 5 in my personal experience. And I'm wondering, is maybe the incidence higher than we think it is, or is there a study in there for me for Michigan water or something, or what do you think?
Well, I wouldn't contact the CDC in Atlanta yet. We've just heard that this is a pretty common problem, and we know that there are sometimes what appear to be clusters of various disorders that are simply coincidences, if you will. So I can't address that specifically, but 5 patients with 5 instrumentalists with dystonia in a specific geographic area would not be all that uncommon, and I don't think that we can make any judgments about some kind of environmental factor, since we don't know what those might be. So I guess it's just bad luck for now, and but it's an interesting observation nonetheless.
I just have a question about some very basic, simple injury prevention things that have to do with the synovial sheath and the ligaments. And commonly, musicians try to select their own wellness things, and so they are getting supplements. And do you have a comment about glucosamine chondroitin? Because I hear from many orthopedic surgeons that there actually is merit to that as a generic recommendation. The second question I have is regarding ligaments and transitory symptoms that teachers may see when teenagers are going through hormone changes or when women are pregnant, and what hormonal changes can affect ligament and joint laxity. And then I have one after that. Go ahead.
Well, as far as the glucosamine and chondroitin, I think the evidence is not yet in. I think most of us think that chondroitin does not seem to have much of a role in therapy. There are certainly some patients that have benefited from rather full doses of glucosamine, and the other side of it is it's not terribly expensive, and at least we don't think there are any harmful effects from it, okay? In terms of ligamentous laxity with pregnancy, largely that tends to affect the larger joints, pelvic joints relax and so forth and so on. The only musician's problem that is affected by pregnancy is the incidence of carpal tunnel syndrome, which has to do with general tissue retention of fluid and is cured by delivery. But I have the number of patients I've had who have been pregnant and I have seen for problems, it would not add up to being an interesting series. I don't think so. I can't address it.
My question actually comes from a dental hygienist that I treated who came in because she has to use all the fine instruments.
Yeah.
And she had significant changes in her hands with her hypermobility in her hands. And so,
while pregnant?
Yes. And so I thought, I wonder if that extends
Don't let your dental hygienist be pregnant.
Well, any others? So the other question I have, I live in a town of about 7,000 people, and I'm the only hand therapist. And in the last year, I have had 7 people come to me with Dupuytren's, and they're musicians. So I'm wondering what incidence of Dupuytren's that you see in your practices.
That's why she turned it over to the surgeon. Obviously, I see more Dupuytren's than others.
They want to know what it is.
I was going to get to that. This is a condition that usually affects primarily Caucasian males more than females, age 50 and up, and it's a thickening of the connective tissues in the palm of the hand and into the fingers to create nodules, lumps, and cords of thickened tissue, which for some people can progress and have these tissues contract down so that a finger can have what we call a contracture. It will not straighten out because of this rope, this tether that's in place. Surgery is the basic treatment for Dupuytren's. Medication and splinting really have not been effective, especially in the later stages. How many musicians? I've had quite a few musicians through my time with Dupuytren's, and as I said, surgery is the only treatment. It is not, however, without its own risks, including potential complications that have nothing to do with the condition itself, and also it requires a prolonged rehabilitation to restore the degree of function that the person had before the contracture exists. This condition is generally painless, and it is generally progressive, and that's about it. Does that answer your question?
Yes, and just to dovetail off of that, I do concur that therapy before any surgery is pointless, and so a teacher that would see this, it would not behoove them to refer the student to therapy because it's really surgery that does it.
Not every contracture requires surgery. Only those contractures which limit function of what a person needs to do in their life.
No, I'm not here to wrap it up. Ralph's going, oh, good, Chris is here. No, I have a question that I would like to ask each one of you, and I'd like to turn the attention more towards the mission of this conference. And if we were to convince the PhD music education programs in the NASM schools, which are probably more endowed to do the kind of research that would contribute to our understanding of these conditions, if we were to convince them that this is an important content area and we get doctoral students thinking about research projects in this area, I'd like to hear from each one of you what you would think would be the most important research agenda that we need to take on at this point in our evolution.
I'll jump
Go
in.
ahead, Ralph.
You know, fools rush in where angels fear to tread. I would like to see a multi-campus prospective study of risk factors for developing performance-related problems. I think we need that to better define what the most effective prevention strategies will be. We then need some prospective studies of those prevention strategies, but I think without better risk factor data, we're going to be taking shots in the dark, and that's going to get very expensive if it's not targeted.
Well, I would invite you all to join us. We at Northwestern have just initiated a prospective study. We've got 100+ students now from the freshman class enrolled in a prospective study, which will be conducted annually, and it's a questionnaire study, and I'd be happy to pass on our IRB-approved questionnaire.
We'd have to get our own IRB to approve it, of course.
I was going to suggest virtually the same thing, but I think there can be some additions. I don't know what your project is specifically, but I would like to see some element of analysis of the patient, him or herself, by a therapist or doctor or somebody for some physical characteristics that could also be looked at as risk factors, since we've all recognized that there are a number of anatomic issues that may predispose to injury. So I would like to add that element, which I think is doable, but it would take a lot of doing to get a physical examination of our musculoskeletal examination, if you will, as part of the prospective study. But I think it can be done.
I think since we're in the mode of expanding on each other's activities here, my first thought is something that is probably worthwhile going down the road on in determining other aspects of musical performance and the nature of what it takes physically to play certain instruments. But I think that beyond the physiological, let's go back to what Dick said about the anatomical, and to see about the advisability of early on youngsters and choice of instruments related to size, joint laxity, and many other factors that could be fit into a research protocol. We know that mismatch of patient to instrument is one of the more important misuse types of activities that can lead to difficulty. And these occur in youngsters as well, pre-college. But these, face it, are your farm team, and we have to make sure that they are as good as possible as well. So here is something that might be added to in addition.
In the presentations, there was a good deal of background information on anatomy and physiology, and then during the survey section, we found that there was strong sentiment that it was important for students to know this information. I think a lot of that presentation and the response from the survey was from the perspective of injuries, again, as we're talking about things, and I would be curious to hear your thoughts on the value of this information just from the pure standpoint of being able to play better.
Well, that's why we teach that to healthy students as well. I think that the more students understand about what they're using, how they're using their bodies, and what's available to use, what the normal range of motion is, how muscles work, the better they're using them. I mean, these are intelligent people, and it's really kind of a crime that they don't have a better understanding. I mean, we used to, when I was in high school, have to learn how to put a car together. We could understand that. We should understand how the body works, the machinery that's running that musical instrument, as well as about the musical instrument. And I think it makes a huge difference in how well they will perform, as well as how they will maintain their health, therefore.
When you were in high school, they taught girls how to put cars together? They didn't do that in my high school. Well, I'm just reflecting history here. You lived in a more enlightened neighborhood than I did.
I'll add a little bit to what Alice said. When a person knows how their body is built and how it works, basic anatomy and physiology, it makes it easier to understand what they are doing technically with their instrument, from respiration to embouchure to hand function, and why the hand cannot reach on the bassoon easily to a C key with the left ring finger, as an example, or why a pianist cannot quickly lift the ring finger of either hand to a rapid degree of motion. Once you have the basic knowledge, then it makes more sense, and people can learn to work around this, and they can learn to use their bodies more effectively to make their music, as well as to live all the rest of their life.
Plus, when they develop symptoms, they have some idea of where those symptoms might be coming from, and again, it's less frightening.
It's inside there that hurts.
But I would just add that this is a testable hypothesis.
Absolutely.
I'm not sure what the exact outcome measure would be, but we can expose some students to information about anatomy and physiology, not expose other students, and then see what happens to their performance careers over time.
Well, there was an interesting experiment done, which we reported in the journal, in Germany, I believe, where two groups of teachers, instrumental teachers, were subjected, one was subjected to real training and one kind of to sham training. Their students didn't know which group had which. And the students, they went back and asked the students what had happened. Was there anything, they had noticed any changes in the teaching methods of the teachers on those who had had the full training and those that had the partial training. And it was dramatic. So they noticed an improved teaching technique as a result of the teachers having been trained, but the kids did not know who had been that they had been trained.
But as I recall, they did not look at any outcome measures in the students themselves.
Other than asking the students whether, not in terms of health, but that students felt that the teaching had improved.
Right.
Without knowing that teachers had had training.
Which is good for faculty development. I'm not sure that it's good for student development.
What you'd have to do is to go further and look at outcome studies as far as the use of the teaching as prevention of, lowering of your incidence rates, for instance.
I'm Roger Warner from the University of North Texas. And I really appreciate your really fine presentations. I've run into a person that had focal dystonia, and it was part of a overall general health condition in which she was not able to even keep her lips from trembling. She went to all of the available medical authorities and neurologists and everything, and they said it's not treatable. She took a project on herself. She said, it can be treatable. I'm going to play my trombone again. And she went on a series of self-help kinds of things, getting information from other sources other than medical the regular medical profession, shall we call it, the other sources. And she has put together for herself actually a curable condition to where she now plays well and even better than before she got this kind of symptom. She is also now helping professional trombone players in major symphony orchestras around the world who come to her as a specialist in working with diagnosed focal dystonia. And I'm wondering do you believe, is this sort of kind of a hocus pocus kind of thing in your judgment? Is it something that's unique to this person that is able to work with these people in this manner? Or where do you stand on these kinds of non-medical kinds of interventions?
Well, first of all, I will tell you that that is not the experience with large numbers of patients with embouchure dystonia. We have been remarkably unsuccessful at treating them. We have been able to do some things which temporarily have seemed to help them slightly for a while, but then they go back. But we're not doing remarkable work with hand dystonia, but a lot better than we are with embouchure dystonia. I will tell you that that diagnosis of embouchure dystonia can sometimes be very tricky. Dystonias of the type that we've been talking about here this afternoon are not typically part of any other general conditions. They are an isolated thing. They're not part of any other neurological condition or any other medical condition. They also principally occur in men. 75% are in men. So I certainly could not speak to that particular patient without seeing her and having been there. In terms of alternative therapies or other things working, again, having seen an awful lot of people with dystonia, and many musicians, many artists will gravitate towards non-traditional medicine, particularly if frustrated by us. And a large number of my patients with dystonia have at some point or another in their careers with their dystonia seen alternative practitioners and have not had terrific results. I mean, they've gone from chiropractic to acupuncture to napropaths and so forth and so on. None of us have been that successful. So it's hard to respond to an anecdotal report like that without really reviewing all the facts. But as I say, the embouchure dystonias have been very disheartening to those of us who see them.
If I may add another anecdote briefly for about a hand dystonia in an oboist in her early 60s, one that I saw while playing and verify what the diagnosis seemed to have been. This woman, essentially on her own as an orchestral oboist, was able to, and here's for our medical crew, she was able to change the sensory homunculus in her hand to recognize the representation of the digits in a different fashion. This lady developed an exercise program on her own that she was able to do during her conditioning walking, and it had to do with being more aware of aspects of her hand physically. And what happened ultimately over about a 4 or 5 month period was she changed this sensory awareness or representation in her brain to bring her digits back to a degree of function that was probably about 95% and got her back to symphony playing. She had a recurrence about a year later, mild, and she went back to her exercises and has stayed essentially free of all symptoms. And I saw her and watched her. She does have, or did have, a focal dystonia. Now, multiple anecdotes do not a series make. I realize this. And until we can find some more people that can be able to document similar type of things, it's going to be difficult. Incidentally, her situation was written up about 2 years ago in the Double Reed magazine.
One of the things that has worked for some patients and we use in combination with our constraint-induced variant therapy is visualization. And visualization, in a sense, does also retrain the sensory mode. They don't do anything with their hands, they close their eyes, and this takes tremendous concentration, but they spend long periods of time visualizing whatever the extremity is that's not working perfectly. They either play through repertoire in their mind or some other thing. And again, that does change, has an effect apparently on the representation in the brain of the affected digit.
I would expect that probably this is what she might be doing, because in her process, she said always concentrate on the musical product that you are going to produce. Visualize it. Use lots of air. Don't worry about whatever's going to happen with the embouchure at all. You just simply visualize it. And she works with these people at for about 6 or 7 hours in concentrated session. And then they come back, and maybe the next day in a portion of a session, then they come back about 4 weeks later for follow-up. And I guess from what she's reporting, and she was supposed to have been here, and I'm sorry that she couldn't make it. She had a conflict. In fact, she had one of her students from Germany that's over here this Saturday. But I'm going to follow up on it, and I'll certainly try to get her to communicate with you. Thank you.
It sounds like these are ones we need to present with PET scans at the next Aspen meeting. But getting back to the nuts and bolts thing, since we're kind of gearing back and looking at the undergraduate School of Music student, should we or should we not spend a lot of time on dystonia? How common is this going to be in the undergraduate music school student, which is what we're working on for our project right now, just in terms of trying to include this in our curriculum?
I think that in terms of teaching, we need to keep it in our minds very much. I think in terms of teaching the students, it should be probably very little, because they're not likely to, I mean, I think you need to mention it because I think they're going to have heard about it. But I don't think in terms of extensive teaching, that's not something they were going to encounter, hopefully ever. And I don't think, there's so many things that we need to concentrate on with limited time that I would concentrate on where their problems exist.
Until we know how to prevent it, I don't think it's worth concentrating on early in the game. If we had a technique of prevention, it might be wise to pass along early. But since we don't, I agree with Alice.
Okay, thank you very much for your very pertinent feedback and your rapt attention all afternoon. It's time to hit the bar.